This is Willie Kemp. This is Disorders of White Blood Cells, Part 6. This is the last one. There are the websites I have with Dr. Hughes where we have questions to help prepare for USMLE and other exams. And then my Twitter locations. I haven't been posting in a while, but I'm going to get back to it. And then, like I said, I am a forensic pathologist. I'm not a hematopathologist, but I have a really strong interest in general and systemic pathology, and I really enjoy teaching the medical students. So pause the recording, read the disclaimer, make sure you agree. If you don't, stop watching the recording. And third disclaimer as well. And then at the bottom, just in case you're interested, I have an introductory presentation that kind of describes me and my teaching methods and everything like that. So if you want to know more about it, just watch that. Here's a list of references that I used. And once again, I would like to thank the University of North Dakota's Department of Medical Laboratory Science. They have a great hematopathology collection, and I was able to photograph those because at autopsy we have rather limited ability to identify things in the blood and that. So just because of the postmortem changes. So here's the question. So once again, pause, go through it, see if you can come up with an answer. Remember, most likely you won't because this is new information, or should be hopefully new information. And the idea is it just gives you something to pay attention for as you listen to the lecture, and you're more likely to retain more. It's a proven technique. So I've been using it for a while. Okay, so myelodysplastic syndrome. Basically what this is it's kind of like the precursor to, in a way. It's kind of like almost dysplasia, but not quite. I guess it's kind of my way of looking at it. It's kind of a clonal myeloid disorder. It results from maturation defects, and that leads to ineffective hematopoiesis, where the cells don't mature correctly, and so you're not able to form the final elements. And then it has a high rate of development of AML. So it's like when you talk about dysplasia with like carcinoma in situ or anything like that, this would be one that is not neoplastic necessarily in of itself, but can easily and quickly develop into an actual leukemia. So basically what happens is a multipotent stem cell retains the ability to produce platelets, red blood cells, and granulocytes, but it's ineffective. So like I said, ineffective hematopoiesis. The final outcome of the hematopoietic cells is they don't produce them effectively, usually around the age of 60 to 70. And so what you can see is obviously if they're not producing the hematopoietic cells effectively, you're going to see loss of red blood cells, you're going to see loss of platelets, loss of white blood cells, which can lead to anemia, thrombocytopenia and bleeding, and risk for infections. So pathologically, you'll see a hypercellular marrow. This marrow is trying to produce the final product, but it's ineffective in doing that. And then because it's ineffective in doing that, you'll see cytopenias in the blood. So it's trying in the bone marrow, but it can't make them, so they don't make it out into the blood. And so you can see some various types of things associated with it. You can see megaloblastic erythroid precursors, ring sideroblasts, abnormal granules, small megakaryocytes. So what it is like I said, it's basically like it's really trying to make these cells, but it just can't. And so they're going to be abnormal forms in that. And I don't have too many myelodysplasia. This is one. So when you look at this, it kind of looks like a neutrophil, but it's not lobated correctly. You can see the granules there and everything like that. So it's basically it's trying to produce them, but what it does end up producing are kind of not normal form. So it says that the etiology for it is mutations in epigenetic factors that control DNA methylation or histones. So once again, just the ability to for the cell to develop normally. Also, RNA splicing factors or transcription factors can play a role as well too. So some of the important points, it says the survival can vary from less than 9 months, and I think with some forms, like even it could be a couple months, to greater than 5 years. It says when it's therapy related, it has the worst prognosis. And as I said before, patients oftentimes do progress to AML. It said about 10 to 40% of those patients do progress. And then when they die, they usually die from secondary defects. So remember, since they're trying to produce the white blood cells, trying to produce the platelets, trying to produce the red blood cells, but don't, they're going to become anemic, thrombocytopenic, and have a low white count. And so because of that, they could die from bleeding from thrombocytopenia. They could die from infections related to the neutropenia. Okay, so myeloproliferative disorders. There are 4 types of myeloproliferative disorders. Chronic myeloid leukemia, CML, essential thrombocythemia, polycythemia vera, and primary myelofibrosis. And so basically with chronic myeloid leukemia, it's chronic, so the cells look more mature. When you hear acute ALL or AML, you think of blasts, and so you have this U chromatin, and so nice smooth nuclei. When you think of chronic, you think of more mature, not absolutely mature, but more mature cell lines. You can actually start seeing the features of what it is, whether it's going to be a neutrophil or that. And then with essential thrombocythemia, they're just producing too many platelets. Polycythemia vera, too many red blood cells. And it says all share growth factor independence, meaning that they're able to grow on their own. And it says it gets these through genetic abnormalities that activate a tyrosine kinase. So CML, this one says usually it's adults usually, although it can occur in children as well, and usually around their 40s or 50s. This, if you're going to know one translocation, I would say this is the one. The Philadelphia chromosome, the 922, the BCR-ABL. And it says ABL is the gene that has the kinase that activates the RAS and JAK STAT pathways, and that's what's going to allow them to have growth independence, where they grow on their own. So obviously it's a leukemia, so you have hypercellular bone marrow, and then those get out into the blood, and so you have an increased number of white blood cells in the blood. And you see a range of them. Like I said, it's chronic, so the cells are more mature. Not absolutely mature, all of them, but more mature. So you won't see the number of blasts that you would see in acute leukemia. So you'll see neutrophils, metamyelocytes, myelocytes, and it's well known for having basophilia. And then because you're producing more, you're going to see extramedullary hematopoiesis, so you can get splenomegaly and hepatomegaly. And then it presents, so it's chronic, so it's kind of slower, and so it's more insidious. It takes a while for the patient probably to come in. They oftentimes have fatigue, weakness, and then they can develop a blast crisis. Now, the interesting thing about it is 70% of those are AML, but 30% are ALL. So what it says is that the chronic myelogenous leukemia, even though it's myeloid, most likely comes from a multipotent stem cell that still has the ability to go along the lymphoid line, and that's the way you get an ALL as the blast crisis. So this is a patient with chronic myelogenous leukemia. To the left of it, you can see just a lot of white blood cells, so a higher white count than normal. To the right of it, you can see so a lot of those you can see neutrophils, you can see ones that look like they're becoming neutrophilic, the more myelocyte, some still have granules and stuff like that, but they're more mature. And then you kind of see that kind of clumped chromatin, that chronic appearance. And at the arrow is a basophil. Basophilia is well known to occur in CML. So to the top left, this is splenomegaly, but without a ruler, it probably doesn't mean much. So the bottom right is the same spleen, and the cross-section there is a normal spleen. So it gives you an idea of what tremendous splenomegaly they can have in a patient with chronic myelogenous leukemia. So it says at about 3 years, you get an accelerated phase where their cytopenias will worsen, they get more mutations, and then around 6 to 12 months after they enter the accelerated phase, they enter into blast crisis. And once again, about 30% of those are lymphoid, which shows that the cell responsible for this is a multipotent stem cell, which still has the ability to develop along the lymphoid line. So I mentioned it before, but I'll say it again here. So anytime you have an elevated white blood cell count and they're granulocytic, the concern will be for a CML, but you always have to remember a reactive neutrophilic response, so a reactive neutrophilia or a leukemoid reaction. I showed this chart before, but the white blood cell count is usually lower in a leukemoid reaction, but it can be fairly high and can be close to CML. And CML is usually higher, but it could possibly be lower. Basophilia is seen in CML. The Philadelphia chromosome is going to be a C in CML. The reactive neutrophilia is going to be have toxic granulation, Dolly bodies. Although when you look at it, you can see some degree of granulation depending upon the precursor cell line or precursor cell. But as they mature, the earlier forms of the neutrophilic precursors have granules, and you can see those in CML. But toxic granules are when you see granules in ones that shouldn't have them. And then the leukocyte alkaline phosphatase is a very useful laboratory test. That's going to be elevated in a leukemoid reaction, but it's not going to be elevated in CML. Okay, so this is just to space my timing through this. And so this is my kitty Mochi. So she's very tired and bored with my presentation. So I hope you're getting more out of it than my cat is. Okay, so polycythemia vera, or I think when I was in medical school, it's called polycythemia rubra vera. Late middle age, like CML, activating mutation of tyrosine kinase JAK2, and so same thing as along the same lines CML. Once again, insidious. It's more of a chronic process, and this leads to an increased red blood cell mass. And because of this, the vessels can kind of more sludge, I think is the idea. So you can get kind of CNS type headache, hypertension, trying to push that increased red blood cell mass through it. They can get pruritus, which I believe can be pretty extensive, and then hyperuricemia from cell turnover, so potentially gout. You'd expect a hypercellular bone marrow, and then actually it can affect others. So you can see elevated white cell count as well too, but the main thing with polycythemia vera still seems to be the red blood cells. You can get spleen and liver enlargement due to extramedullary hematopoiesis, and then in the spent phase, the bone marrow can actually become fibrotic. So laboratory testing, the erythropoietin concentration should be low. So polycythemia vera would have to be differentiated from polycythemia, and polycythemia, most times you're going to have an elevated erythropoietin, and there's other ways to help determine them as well too, but in polycythemia vera, there's no drive from the body to increase the number of red blood cells, whereas in polycythemia, the elevated concentration of erythropoietin is what's driving the increased number of red blood cells. So this was one of these were in study sets I had. This was spent polycythemia vera. So you can just see this fibrosis of it. So looking at this, you would not be able to tell that was a diagnosis. What you do is you can look at it and say, yeah, the marrow looks fibrotic, and I don't see hematopoietic cells. But as far as saying this is a spent polycythemia vera just from the picture, I wouldn't want to say that. It obviously can be, because that's what happens with polycythemia vera. Toward the end of it, it can get fibrotic. But basically all you can say is there's a fibrotic marrow. So there's a risk of thrombosis and or bleeding, because with the idea, I think that with the increased red blood cell mass, the blood gets more sludgy, can slow down through things, and that's why you get some of the clinical presentation. They can get Budd-Chiari if you get thrombosis of the hepatic veins, and then about 2% of patients transform to AML. So not near as much as CML transforming to AML, but still some of them can transform. And then essential thrombocytosis, same thing, around the same age, same type of mutation, with the name elevated level of platelets, but they're dysfunctional. And so because of that, even though you have a normal platelet count, or sorry, a high platelet count, the platelets are not normal, and so that you can still have bleeding in that. And then what you'd expect, megakaryocyte hyperplasia, because it's pumping out more platelets than normal, so they're going to be increase the precursors of it, the megakaryocytes, and the platelets can be abnormal, so they can be enlarged in that. This is what I think is one of the better ones to have. The survival is usually around 10 or 15 years, and they very rarely develop into AML. One thing I was reading, it says they can have something called erythromyalgia, if I pronounce that correctly, a burning and throbbing sensation of the hands and feet due to platelet obstruction of arterioles. I assume there would be other things that have similar, but in reading Robbins, this was the one they linked it with. And then primary myelofibrosis, same thing as the other ones, around the same year of age, same type of mutations. And then the mechanism, platelet-derived growth factor and transforming growth factor beta are fibrogenic, and that's what you're going to see in myelofibrosis. And so basically you get fibrosis of the bone marrow. If you fibrosis the bone marrow, you're going to lose the hematopoietic cells that are there, so therefore you're going to get cytopenias. You're not going to be putting out the cells like you should be. You'll see extramedullary hematopoiesis, because if you can't produce hematopoietic cells in the bone marrow, you're going to produce it in the liver and spleen, and then because of that, you're going to get splenomegaly as it enlarges, because an increased number of cells are being produced there, and so therefore the organ is going to be bigger. And this is myelofibrosis. Obviously, if you're going to diagnose this, there are a lot of things that can cause bone marrow fibrosis that are not necessarily a myeloproliferative disorder, so you'd want to know more from that. But this is just an example of myelofibrosis. Oh, sorry, Langerhans cell histiocytosis. When I was making this lecture, when I first started recording it, I went back through and I realized that there were a couple things I didn't do to it, so I fixed up, I added a question and stuff like that, but I forgot the demographics there. I apologize. I've just been really trying to get these lectures out for the students I'm working with currently, and before I am gone for next week. So sorry for a couple of things here and there. I apologize for that. But Langerhans cell histiocytosis has a BRAF mutation most commonly, but there are other ones as well too. The characteristic are these grooved or folded nuclei, and you can see vacuoles. And then I think the big one for you all to know is the Bierbeck granules, which are associated with Langerhans cell histiocytosis, and it basically looks like a tennis racket. And then the immunophenotype is there. And there are various forms of Langerhans cell histiocytosis. The letter Siwi, eosinophilic granuloma, and then pulmonary Langerhans cell histiocytosis. And I just put kind of what was listed in Robbins. To me, it's a pretty rare disorder, so pathologists really want to know about it. But I think for medical students, it's probably one of the lower ones on my list to absolutely be able to pick up all the details on it, because it is relatively rare. And I think oftentimes the questions on exams, they want you to understand mechanism, common diseases really well, complications, things like that, and more rare. But it's in Robbins, so I'm including it there. Okay, so as I said in a few of the other lectures, at the end of this one, what I did was I just made some charts. Two of them. One has basically a lot of the big translocations that are associated with it, just for you to look at. Most of these I think are pretty ones you should know, because like T1221 in B-cell ALL has a good prognosis, and that's one commonly associated with it. T922 is known for being in adult ALL. Notch1 is important in T-cell ALL, and that has the characteristic presentation with the mediastinal mass and the adolescent males. Burkitt's, that one's important to know. Diffuse large B-cell, remember, it says it's kind of heterogeneous, but those ones associated with it, so that's probably maybe a little lower on the list. Extranodal, very characteristic, and also it's a great test question, I think, the development of associated with a chronic inflammatory process. Follicular lymphoma, very important to know, and then the BCL2, so the idea that there are immortal. BRAF and hairy cell leukemia. Mantle cell, very important to know, the 1114, the cyclin D1. Chronic lymphocytic leukemia, I would say probably is lesser than some of the other ones. AML, the 821. Inversion 16, 15, 17. CML 922. And then the characteristic association of the JAK2 and the polycythemia vera, essential thrombocytosis, and myelofibrosis. So I think a lot of those up there are very important. Oh, and sorry, the anaplastic large cell lymphoma and the ALK positivity. I think those are good to know. Then the other thing I did was, because when you're going through this and you see all these CDs, it's like, oh man, it's a lot to remember. And so I just want to kind of go through there. And so I think really if you remember for a lot of them, if you remember 19 and 20 or B cell, that's good. Most of them are going to be CD10, but the ones that stand out are like TDT for the very immature. Plasma cell has its own, and then CLL and mantle cell are CD5 positive, which is really good to know, because that one is one that should not be there. It's a T cell marker, not a B cell marker. And then hairy cell stands out because it has the 11C and the 103, which are not seen in other ones and stuff like that. So I think if you concentrate on, instead of memorizing each one by one, concentrate on what stands out. And sometimes that's a lot less information. It helps you just as much on an exam. So here's the question. So pause, answer the question, and we'll go through it in the next slide. So it's 922. So this is CML. You can see a range of maturity of the cell types there. And then in the bottom left, you can see that dark purple is the basophil. So this is CML. And then the patient, if you have the leukemic infiltrate, they can present with potentially anemia. They can present with thrombocytopenia. They can present with infections because their granulocytes producing are not what should be produced and everything like that. Okay. So at the end, again, of course, reflection. If you would, just pause, think back. What are 5 important points I made during the lecture? And this is a really good way to cement the information. Like I said, I'm not doing a summary because I want you to do this on your own and not just be able to go to the next slide and see what I thought were the 5 most important points. Like I said, very good technique. I've started using myself, and I think I actually used it without thinking about it back in college. So I highly recommend it. So this is outside my house in Billings. This was just a couple days ago. We got about 6 inches of snow in April. I've lived in Montana most of my life, and I remember being snowed on every month out of the year. I remember at Carroll, we got snowed on in August. It snowed 6 inches, and so not quite like some of the other parts of the country. So I hope this lecture has helped you understand neoplastic disorders of the white blood cells, and thank you.